So looking at the IGEL, this does not have any type of inflation. And the way that this works is it actually comes in and makes this seal against the trachea. So you can see here in this picture that the distal end goes into the esophagus just like the King tube did, but it's actually creating a seal around the trachea to force air down there. So while this isn't placed into the trachea, it is creating a seal there to push air down. Now, the IGEL is going to be sized based off of weight. And so just like previously with the King tube, the most common sizes are 3, 4, and 5, but there are some child sizes here as well. This has no inflation like the King tube did, so this is really kind of a cram it and jam it if you want to be kind of coarse about it. So it goes directly in, there's no inflation, it makes it seal, and it's really effective and it's really quick, and so that's why it's becoming the choice of pre-hospital providers. So you would take this directly out of its packaging, place the lubricant on it, you're looking to make sure that there's no deformity or anything there, then you're going to grasp the IGEL. You can use that same BASS maneuver that you did for the King tube, and you can hyperextend the neck if the patient's cervical spine will allow. If you suspect a spinal injury, then you can leave them in a neutral inline position and use that BASS maneuver. You're going to gently push the chin down just a little bit, insert it in, and then you're going to push it in until resistance is felt. It's pretty simple. And again, confirm your tube placement with the methods that we previously discussed. So this is one of the most effective and quickest methods to use a blind insertion device. Now, the LMA is very similar to the IGEL, and so it does have an inflation port. That's really the difference with the way that it goes in, the way that it's inserted, the way that it creates that seal are just exactly the same as the IGEL. The difference is this just has that inflation port to inflate the cuff and make the seal, whereas the IGEL is already there. So these are all, again, weight-based. These are most common in hospital settings. These go all the way down to infants, neonates, so all the way up to adult sizes. And so you might see these carried in a pre-hospital setting, or you might see them if you're working in a hospital-based setting. But there you go, that's the LMA. Same concept as far as insertion, choosing the correct size based off the patient's weight. You want to inflate it, test it, lubricate it whenever you get ready to put it in. And this is how it winds up lying. And we will go over all of this when you are on campus and we are talking about advanced airways. Now, this is a Combitube, and as I mentioned at the beginning of the first video with advanced airways, this is the oldest type of device, and it is a dual lumen device, so it's similar to the King tube in the way that the cuffs are inflated, but it has two ports for inflation, one for the distal and one for the proximal cuff that both have to be inflated, and it also has two ventilation ports, which means that if it is placed accidentally into the trachea, it will still work because air can either come out of those holes like it did with the King tube, or it can come out at the very end. And so this is a really unique device in the fact that it is almost foolproof. It will work no matter what, but because it's a one-size-fit-all, it did cause a lot of potential damage and bleeding to the airway if it wasn't properly inserted. And so that's why people started moving away from this and moving towards devices that were more uniquely fit to the size of the patient. So again, very important. But this is how it winds up lying, and again, you would be able to have a numeric reading on this so that you're looking to see, no numeric reading on this, but there are two black orientation lines so that you can kind of see if the teeth are lying between those two lines, then this is ideally in the correct place. But we know that people have different size airway anatomy, and so again, this is why people are moving away from this. But these are those two black orientation lines, so the teeth would lie right in between this. You have your proximal cuff, this bigger one, which would be inflated with more air, so a bigger syringe, and then the distal cuff a little smaller, inflated with a separate smaller syringe right here. These same methods of orientation as far as putting it in as it was with the King tube, so I'm not going to read through all of these steps. The biggest thing to remember is that if you ventilate down one cuff and it does not work, then you would move over to the second one, and the theory is that it should work. All right, almost foolproof. So again, if the distal cuff is placed into the esophagus, the balloon will occlude the esophagus and the stomach contents can be safely expelled through the hole in the end of the tube without risk of aspiration, which is while air is being forced into the trachea, same way as the King tube. If it is placed into the trachea, then it works just the same as an ET tube would. Now let's talk about confirming tube placement. I mentioned these a while ago, but again, just saying no matter what method that we are choosing here, whether it is going to be King tube, LMA, IGEL, Combitube, we're looking for proper confirmation of tube placement. And so we're looking for good chest rise and fall, equal and bilateral. We're listening for lung sounds, ideally clear and equal, all right, with ventilation. And then using some form of capnography, whether that's going to be color change, which is least effective, as we talked about in vital signs, or one of those that we can monitor with numeric and waveform, which would be the best option to give us continuous feedback. Now, use of some form of capnography is mandatory with an advanced airway placement in the state of North Carolina, and an additional form needs to be filled out as well, saying that we did monitor this advanced airway the entire time that it was in place. Now, once you are going to secure a tube, you have two options. You have a commercial device like what you see here in the picture. IGELs have their own version of this, but they're a little bit wider, made specific for their tube. The more narrow ones would be good for any of the other sizes, whether it's a King tube, if it is a LMA, a Combitube, or even an ET tube, they would all be more fit for that narrow version. And we'll show you how to put this on when you are here as far as limiting the movement of the head and potential dislodgement for the tube, but you always want to make physical contact with the tube, holding on to it until it is secured one way or the other. If you don't have a commercial device like this, you can use tube tape to secure it. Again, a double-sided sticky tape that will secure it to the side of the mouth and hold it in place. So that's it for advanced airways. Hopefully this has been helpful for you guys, and we will see you in class to get hands-on experience with putting these in.